Good afternoon. Thank you for the introduction. I'm very honored to speak with you today on a topic that is both timely and deeply important. So opioid use disorder in pregnancy represents a really vulnerable period for both the mother and the baby, and I think we really have a responsibility to address it openly to improve outcomes. I don't have any disclosures. So today, I'm going to discuss very briefly the prevalence of opioid use disorder in pregnancy and its impact on maternal as well as fetal outcomes. I'm going to review some evidence-based therapies for opioid use disorder and some important treatment considerations. And then finally, I'm going to address some of the stigma in perinatal care and outline some best practices for providing really compassionate, patient-centered treatment. So I'm sure you guys are all aware that opioid use disorder in pregnancy has escalated dramatically in recent years, really paralleling the epidemic observed in the general population. So nationally, when you look at these numbers, the prevalence of opioid use disorder has more than doubled between 2010 and 2017, and really quadrupled if you look even further back from the 90s. And these trends, unfortunately, are a lot worse where I'm from. So the states that are really the most affected are Vermont, Maine, Massachusetts, Rhode Island. Another proxy for the severity of the opioid epidemic among pregnant populations is the incidence of neonatal abstinence syndrome, which has escalated dramatically. So that's in the yellow over here. So neonatal abstinence syndrome is really, if you don't mind going back one slide, sorry about that. It's a drug withdrawal syndrome, generally in about 60 to 80% of babies that are exposed to opioids in utero. So why is this important? So for most anesthesiologists, interactions with this patient population, when they come and ask me questions like, how do we manage this, really focuses on post-operative pain management, which can often be very challenging. But there's a much larger problem to really recognize. It turns out that opioid misuse in pregnancy significantly increases the risk of poor maternal and perinatal outcomes. So much of the data I'm going to present today, I'm thrilled to say, was spearheaded by folks in this room, like Dr. Leffert and Dr. Bateman. Dr. Maida and Dr. Leffert really were instrumental in this work. So this is a large sample size of about 20 million women, and here we're focused on patients with opioid addiction, opioid dependence, and non-dependent opioid use in the blue. So the blue are opioid users, and the red are non-opioid users. And even after adjusting for sociodemographic factors and chronic pre-pregnancy conditions, opioid use disorder was associated with an increased odds of major obstetrical morbidity and mortality, including in-hospital mortality. So if you take a look here, so 2 times higher odds of preterm labor, much higher odds of placental abruption, and women who used opioids. Right here, sorry about that, okay. So women who used opioids during pregnancy were twice as likely to have prolonged hospital stay exceeding 7 days, and were more than 4 times as likely to die during their hospital stay. As you can imagine, opioid use is also associated with worse outcomes in the fetus. So nearly 3 times increased odds of IUGR and increased odds of stillbirth. And you may be asking, at least this was a question I asked, why is this happening? So, more research really needs to be performed as far as direct mechanisms that could lead to this problem, as I think the causes are really multifactorial. So one factor is certainly that women who abuse opioids certainly tend to seek prenatal care late in their pregnancies. Certainly a higher rate of C-section in this population can lead to increased transfusions, challenging pain management, and increased morbidity in general. But another factor that I think is really unrecognized and likely contributing to this problem is opioid withdrawal. And so opioid withdrawal is extremely taxing to maternal and fetal physiology. So repeated episodes of opioid withdrawal, essentially what happens is as a mother experiences withdrawal from medication, from something like fentanyl or previously heroin, there's an increase in catecholamine release that leads to subsequent vasoconstriction, increased uterine contractility, and decreased placental blood flow. And likewise, in the fetus, something similar is happening. So the fetus also experiences withdrawal. So there's an increase in oxygen requirements from hyperactivity. The circulating levels of catecholamines go way up. And essentially, they've actually seen higher levels of catecholamines in the amniotic fluid of women who have acutely withdrawn from medications like methadone. Also, lower gestational age in this population, as well as an increased frequency of preterm birth. So although I probably won't be showing that to my kids, this is not the population to be, removing opioids in this population. And avoiding repeated cycles of withdrawal is an extremely important tenet in the management of these patients. So I think you guys all know that medications for opioid use disorder is really the standard of care. So all women should really be screened, all pregnant women should really be screened for opioid use disorder in pregnancy. And in non-pregnant patients, this is associated with a 50% reduction in mortality. So the medications that we use, methadone has been used since the 70s. Newer drug, not so new anymore, is buprenorphine, multiple different types. So Subutex and Suboxone are essentially in tablet form, in film form. There are some injectables that I've seen a lot of women using, and they've continued throughout pregnancy, so you guys may be seeing those as well. So Sublocade is a monthly injection. Brixadi actually offers a lot more flexible dosing with both weekly and monthly injections. And neither has really been recommended for routine use in pregnancy due to lack of safety studies. However, practically, many women are on these medications. And Brixadi, actually, because you can inject it weekly, I think you're going to see a lot more of that in the future. Naltrexone is a non-selective, long-acting opioid receptor antagonist, which really offers sort of a unique opportunity to remain opioid-free in pregnancy. However, pain management can be tough, and there isn't a lot of long-term safety data in the fetus, although you will be seeing that drug as well once in a while. So there's a lot of risk-benefit analysis as far as keeping these medications on board or deciding to stop that. So which maintenance drug is better to use in pregnancy? So very important to mention a landmark trial in 2010 in the New England Journal of Medicine called the Mother Trial, which essentially compared buprenorphine versus methadone maintenance in pregnant women with opioid use disorder. And for those of us who sort of read and study a lot about these medications, I think we were all surprised at those results. Now, subsequently, Dr. Bateman's group examined similar outcomes with this large cohort study involving pregnant women from 2000 to 2018, and had an adjustment of a lot of confounders that were present in the Mother trial. And this study further reinforced the evidence that buprenorphine is associated with a lower risk of adverse outcomes, neonatal outcomes in methadone use in terms of the incidence of neonatal abstinence syndrome, preterm birth, small size for gestational age. However, there was no difference shown as far as maternal complications or the rate of C-section. So a few just sort of general treatment pearls as far as maintenance therapy. So despite the data I showed you about buprenorphine, if a patient's on methadone, we're going to continue it throughout. Pregnancy, post-op, all of the rest. Similarly, with buprenorphine, we're going to continue throughout pregnancy and perioperatively. Oftentimes, these centers that have fancy acute pain services will drop the dose perioperatively in non-pregnant patients, or we'll do things to minimize the agonist effect on the receptor. But in pregnancy, we can easily achieve good pain results even at greater than 16 milligrams because we have all these other regional anesthesia tools. And also, more importantly, discontinuing or reducing the buprenorphine can really lead to an increased risk of relapse. Despite the data I showed you, we're not going to switch from methadone to buprenorphine, again, because it's a partial agonist that, again, introduces a risk of relapse. And one thing to note is that most of these patients will require an increase in their dose in their third trimester. So because the increased clearance and rapid metabolism, it can be really difficult to control withdrawal symptoms for 24 hours on a single dose. So generally, because of the increase in total blood volume, protein binding, increased hormonal levels, we do see that it's necessary essentially to do split dosing. So instead of Q-day methadone dosing, you're going to see BID. Instead of BID dosing for buprenorphine, oftentimes you'll need TID or even QID dosing to just prevent those withdrawal symptoms. So I wanted to switch gears a little bit to another challenge that I faced in treating these patients, and I just wanted to touch upon a little bit about what I like to call a hidden challenge in managing these patients, which is really confronting the stigma and bias. So healthcare discrimination is extremely common and really stems from antiquated and incorrect beliefs that addiction is a moral failing rather than a true diagnosis. And I've witnessed many times that even my own colleagues, these two mainstay evidence-based therapies of methadone and buprenorphine that we recommend, they feel that somehow these medications were simply replacing one opioid or addiction for another in patients that are really lacking the willpower to stop completely. And I've seen a lot of mistreatment of these patients. So I wanted to bring up a couple of studies. So here is one, 100 patients, essentially 57 of them reported healthcare discrimination. And this included being shouted at, scolded, threatened, being ignored, told they weren't allowed to have their pain medications. And as you can imagine, with all the other talks that have been given this morning, racial disparities have really only exacerbated this problem. So compared with white women, black women had a substantially lower likelihood of essentially receiving any medication for the treatment of opioid use disorder, and a much lower likelihood of receiving buprenorphine. Pregnant women of color also received about 67% of the dose of methadone at delivery than that of white women. So bias is really pervasive. I wanted to put this slide up because I wanted to sort of bring home the point of how these biases can impact these women. So this is some data out of Massachusetts, population-based retrospective cohort study obtained actually in Massachusetts. And the yellow represents women on pharmacotherapy with methadone or buprenorphine. And the green are women not receiving pharmacotherapy. And so overall, what we're looking at here are fatal and non-fatal overdose rates among women throughout pregnancy. And as you can imagine, the women who are receiving pharmacotherapy was significantly lower as far as overdose rates compared to those who were not on any sort of pharmacotherapy. So here's intrapartum and postpartum. And interestingly, the highest rate of overdose was at 7 to 12 months, which I found actually sort of surprising. But I think that's an especially vulnerable time for women because there's fewer special services that continue after delivery. So understanding and recognizing stigmatizing behaviors and the drivers of these behaviors, I think is very important in stopping them. I've thought a little bit about why this is happening. And, so I think there's sort of a cycle of how this works, and it sort of perpetuates stigma. So we have all these stigmatizing behaviors, right? So assuming these patients are irresponsible, less deserving of care, there's a lot of stereotyping, so viewing pregnant patients with opioid use disorder as dangerous or untrustworthy, and the us versus them mindset, a lot of dismissing symptoms, so sort of withholding pain medications, and ignoring guidelines, frankly, as far as maintaining these women on therapy. And I I think a lot of these stigma are compounded, but what I like to call intersecting stigma. So there's a lot of, socioeconomic factors that worsen this stigma. There's some cultural-based intersecting stigma, so media stereotypes about pregnant women, with opioid use disorder being unfit mothers, the belief that I mentioned that opioid use disorder is a moral failing. And then there's a lot of structural and policy-related intersecting stigmas. So I'm not sure if any of you have ever been to a methadone clinic, and I've worked in one before, and I have to tell you that, the daily lineups, the urine testing, it all just perpetuates the notion that this is a form of discipline rather than healthcare, right? So, they're not really nice, warm places to be. And I think this just perpetuates the stigma, and they're extremely restrictive. And then there are, of course, a lot of medical and clinical stigma. So many of these patients have have Hep C and HIV as well, which have their own biases associated with them. And then there's a lot of limited provider knowledge about how to even treat these patients. And so I've heard some nurses, some doctors, I've witnessed them say, you really should try to take less of these medicines. And so I think there's a lot of room to expand knowledge in this space. So with those stigmatizing behaviors, you can anticipate what the response is going to be as far as the patient reaction, right? So they don't want to come see us, right? If they're being treated that way. So there's a loss of trust in the healthcare system. There's avoidance. There's increased risk-taking as far as taking medications to manage their withdrawal. And then there's a lot of shame and secrecy about their usage. And the consequences are also quite obvious, right? So missed and fragmented prenatal care, poor some of the outcomes that I mentioned. And then I think the secrecy, it just ends up perpetuating, right? So I've heard conversations amongst physicians where they say, I went into her medical record and guess what? She actually, she has been using fentanyl this whole time in pregnancy, and she was a liar. And it just perpetuates this notion that these patients are dishonest, and it's just a vicious cycle of stigma. So things that we can do. Language is an extremely powerful tool, and healthcare providers who hold more negative beliefs about opioid use disorder, I think, can really unwittingly isolate and traumatize this population with harsh words. So our words can really convey support and encouragement, but can also create barriers to treatment and recovery. So I've heard all of these words on the left by very well-intentioned people and providers. I think a word that I used to use early when I was treating some of these patients was clean, and I quickly kind of felt like, wow, that doesn't feel like a good word, if the opposite is dirty. Other words up here like habit, abuse, they're just better terms to use that can convey more support. The other things that we can do is to try to see the person behind the pain. And there are a few tools, take it or leave it, a few tools that I feel like have helped me really connect with these patients. The first thing that I've tried to do is to really spend the first few minutes finding just one point of connection. And you may say, how is that even possible with some of these patients? But this can take some work, but find a point of connection that's genuine. This can be anything, a hometown that you share, a shared frustration with hospital coffee. This past week, two of the patients, one patient actually, as far as an example, one patient had the same stuffed animal that my son has. And another patient, when I walked into her room, she had an all pink bag of Starburst candies. And I was like, wow, you and I share the same candy. We have the same love of the same candy. So I think that can really just connect you with the patient and humanize the patient. The second thing I do with all of my patients, and this has really been a learning experience, is invite them to tell their story. And And I usually say, I'd like to understand your journey. Can you share how fentanyl first became part of your life? You will be shocked at the answer. They want to tell their story. And I found that the most powerful in connecting with these patients. The other thing is to sort of move from measuring to understanding. So really sort of walk in with the mindset that the patient's report is real and worthy of attention without really being quick to judge right off the bat. And finally, I've really changed the way I use the VAS scoring system. I think I've noticed a lot of perseveration and frustration of healthcare workers around this pain score of 0 to 10. I said, oh, Dr. Kamdar, I walked in and she was sleeping, and then I woke her up and she said her pain's a 15. Or she was on her phone and her pain is 11. Like, how is that possible? So rather than thinking of the pain score in that way, I sort of made my own pain score up. And and I think this is good for the trainees as well. So for me, a 10 is I can't talk and I can't breathe and I can't move. A 5 is I can do everything I need to do, but not the things I want to do. And a 0 is I can do everything I want to do. So I asked the patient, can you walk me through what you can and can't do? So more of a functional pain score, essentially, rather than, tell me what your pain score is. Finally, and this one I think is extremely important, give options. So do you want to drop the ketamine infusion today, or do you want to drop your IV Dilaudid? Empower these patients to help make some of the decisions as far as pain management. So caring for pregnant patients with opioid use disorder has really been one of the most meaningful parts of my work, but also one of the most humbling. And so, it's been a challenge for me to recognize and intentionally dismantle, I would say, my own biases. And I want to be honest with that and be brave. So I'm going to share a story about my own journey. And this is a true story, and I've received patient permission to share it. So I'm just going to read this. So when I was a CA2 anesthesia resident, I was asked to remove an epidural for a young woman who had just undergone a cesarean section. The patient was 20 years old and had a history of opioid use disorder with heroin. I remember going to her room for this seemingly simple task, but when I entered, she was crying and in too much pain to sit forward for me to access her lower back and remove her epidural. I went to my OB anesthesia attending for guidance, and he followed me back into the room. He suggested that it might be easier with an abdominal incision to lie her completely flat and roll her to one side, which seemed very reasonable, but she adamantly refused to lie flat on her back. The more we pressed, the angrier she got, and the more distressed she became. Eventually, with IV Dilaudid and a large epidural bolus, we helped her lean forward. As I focused on her spine prior to pulling the epidural, I noticed a dark, moody tattoo etched across her shoulder, which said, "For every dark night, there's a brighter day ahead." I didn't think much of it at the time. We removed the epidural and stepped out of the room. The nurse followed us out and muttered in frustration, "Wow, that drug addict is a nut job. She should consider getting a tubal so she doesn't bring another addicted baby into this world." My attending added, "That's an understatement." I felt really uncomfortable by these words, but nodded my head in agreement. Fast forward to nearly 2 decades later, and I was attending on the acute pain service where we were consulted for a 38-year-old woman with opioid use disorder recovering from an open heart surgery for infective endocarditis. The cardiothoracic surgeon fellow called me and warned me, "Brinda, this patient is totally crazy. All my resident tried to do was remove one of her chest tubes, and she started cursing at us and totally flipped out." Later that afternoon, I met the patient with the entire pain team. The patient was disheveled, missing both legs, and most of her teeth. Tearfully, she explained that earlier that morning, while she was half asleep, a surgical resident came in, put the head of her bed down, raised her arm, and yanked out the chest tube without warning. She felt violated. I apologized on behalf of the team and assured her we'd approach the remaining drains and tubes differently. We discussed many sedation options: Dilaudid, ketamine, Valium. She was open to anything, as long as we didn't put the head of her bed down and lie her flat again like that. Then I asked a question I already suspected the answer to. "Why can't you lie flat, my friend?" She lowered her gaze. From the time I was 12 until I was 14, my stepdad assaulted me at night. I've slept upright in a chair with my arms crossed over my chest ever since I ran away from home, so I can be ready, so I can protect myself. The room was silent. We listened as she told us how, after running away from home, she spent a year of high school sleeping on a friend's couch until she was no longer welcome, how she then lived on the streets, and how at just 16 years of age she began using IV heroin. We made a plan for the remaining chest tubes removal: sedation with our team at the bedside, seated position, full control in her hands. As we prepared to leave, she stopped me. "Dr. Kamdar, before you go, can you help me adjust my pillow?" As she leaned forward, her gown shifted, and I couldn't help but notice a tattoo on her shoulder. For every dark night, there's a brighter day ahead. It was the same patient. Thank you, guys.